Hello, everybody. I am Xavier Wittebole from the Critical Care Department of the Saint-Luc University Hospital located here in Brussels, Belgium. I would like to thank Professor Vincent and his colleagues for providing me with the opportunity to give you this talk on some tricks we could use in patients in order to help them improve their oxygenation. I have no particular conflict of interest to declare with this lecture. So you all know how to provide oxygen in acute respiratory failure patient, from nasal cannula to various devices we can use, nasopharyngeal catheter, oxygen face mask, and of course the face mask with reservoir bag or non-rebreathing mask. And finally, the high flow system, high flow through nasal cannula, which can deliver a high amount of oxygen through the flow to the respiratory system, which flow can go up to 40, 50, 60 liters per minute, which is, of course, certainly high enough for a usual patient. But in some cases, the inspiratory flow of the patient could be as high as 100 liters per minute when they are really in respiratory distress. And the flow, the amount of oxygen which is provided through the system to the patient will, of course, depend on the flow, but also on various other conditions such as the open mode or the closed mode from the patient and the nasal cannula size. And so these are the various systems we can use. Before going further, I would like to remind you about the fact that when we give oxygen to the patient, this is a treatment and it should be prescribed, and it should be prescribed with some targets. And the latest recommendation propose not to provide or to decrease oxygen if the target saturation is 96% or above. It also recommends not to start oxygen if the saturation of oxygen is at 93%. And in some cases, but this recommendation is weaker, I would say, if it's above 90%, not to start oxygen either. So we should keep the oxygen saturation between 90 or 93 and 96%. So how to improve oxygen in those patients? Well, we could use usual oxygen providers. We could make some tricks and use some systems during high flow. We can take the patient out of bed, and that's something we sometimes forget. And of course, you've certainly seen a lot of literature about proning patients, even if they are awake, using the high flow system or other system, just like non-invasive ventilation. So the first system we could use to improve oxygen is the Tusk mask, which was initially described back in the early 90s and proposed in critically ill patients in 1998 by Natyuk, who proposed to use some device here added on the face mask, which mimics actually the tusk from the elephant, and to help improve the oxygenation. We have some colleagues in Belgium. We developed the double trunk mask, which is a system. Here you can see it is used on the high flow system. We will discuss this a little bit later. And so the data are actually quite interesting, because with the simple Tusk mask, which is a simple modification of the partial rebreathing mask, it used two pieces of respiratory tubing or Tusk to deliver high flow FiO2. And indeed, it helps to increase the fraction of inspired oxygen that was described in the early 90s, and in critically ill patient and in patient with interstitial lung disease. It also helps to increase the PaO2. The double trunk mask is a similar face mask, which is composed by a normal aerosol mask with holes within the aerosol mask and different length of tubes, flexible tubing inserted to each side of the mask. It is just applied to the face of the patient. The first report from this double trunk mask was back in the early 2000s, and you can see here that indeed the double trunk mask certainly increased the PaO2 of patient without a change in the FiO2, of course. This was further confirmed with the nasal cannula, the recently published paper, and you can see that adding this double trunk mask on patient with a face mask on the nasal cannula well allows certainly an increase in PaO2 and the P2F ratio without a significant change in PCO2. So this is another study performed and published 1 year ago in critically ill patient receiving high flows through nasal cannula without any change in the systems. And you can see again that there is a significant increase in the PaO2 when you use this system of double trunk mask, plus 26%. So how does it work? Most probably because it decreased the entrainment of room air when the inspiratory flows is above the flow delivered by the high flow system. So the actual FiO2 is increased and is probably closer than the set FiO2 to the set FiO2 to the system. In this study with the high flow system, there were 4 patients who did not respond. So what is the reason for that? Most probably because the inspiratory flow of this patient was below the flow delivered by the high flow system. And so the addition of the double trunk mask didn't really help in those patients. We did adapt the system recently with the COVID pandemic. We use actually face mask. Actually, this was required by the hygiene department, who didn't allow us to use the high flow system without putting a face mask, surgical face mask on the patient because of the fear of the spreading the disease to the healthcare personnel. So we enrolled 21 study admitted because of COVID-19 related acute respiratory failure. All these 21 patients were treated with the high flow system, and we performed the study in 3 steps, so a kind of double crossover. So they were on the high flow system and were stabilized after a 30 minutes period. We took a blood gas at that time. We put the surgical mask, left the patient with the surgical mask on the high flow system during 30 minutes, and then we removed the face mask again just to be sure that the improvement we observed was not related to the improvement of the disease. We performed arterial blood gas to assess the PaO2, and actually at the very beginning we wanted to be sure that there were no increase in the PaCO2. And what we did observe is actually a really large improvement in oxygenation parameter, with an increase in PaO2, increase in saturation, and an increase in PaO2-FiO2. We also observed an increase in PaCO2, which was statistically significant. But when we look at the data, going from 32 to 35 PaCO2 is probably not really clinically relevant. As usual, with the COVID pandemics, we had mainly male patients. The BMI was about 28, and the mean FiO2 provided by the high flow system was about 75%, with 60 liters per minute delivered. We did not change the settings, as I mentioned, during the study, to be sure that the improvement was well related to the placement of the surgical mask on the face mask. And you can see here that after removing the face mask from the face of the patient, well, the value of the oxygenation went back to normal. We didn't perform an arterial blood gas at that time, but the saturation went back to the previous value before placing the surgical face mask. So really a simple method to help the patient improving their oxygenation. Another study that we performed 2 years ago and that will be published soon is to assess the efficacy of taking the patient out of bed. And we used the electrical impedance tomography to assess the ventilation and the recruitment which is allowed with that kind of system. So what we did is taking the patient out of bed. We had a patient on mechanical ventilation or breathing spontaneously, and then we had a control group, and we took the patient out of bed and the control group was out of bed also, but in the control group he also performed some exercise, so out of bed in a chair, cycling with the arm or with the feet, and then we had some recovery. And what we did observe is that indeed we increased the impedance from the patient, and we also improved oxygenation of those patients. You have here the P to F ratio, and the patient who most benefit from being out of bed were the patient with the P to F ratio below 200 at the time when the study starts. So at the time they were still in bed. So going out of bed and performing some exercise certainly may help the patient to improve their oxygenation. So the conclusion of our study was that the sitting position coupled with early exercise is an effective method to increase lung aeration and oxygenation in critically ill subjects. So the last point we can do to help the patient is to prone them even if they are not sedated on mechanical ventilation. So you've seen a lot of paper published over the last weeks on this, and we did this for many years now in our site. We never published our data, but then you can have those data published now. I don't want to go too much into details on this, but you can have this. You can prone a patient with just simple oxygen procurement, or during non-invasive ventilation, or with the high flow system. For instance, you have here a recently published paper showing that LMS non-invasive ventilation can be improved with oxygenation, and you have the same thing here with some result with the high flow system, showing that when you prone the patient, you improve the oxygenation. Of course, we have to have a protocol, and some protocol have been proposed very recently to help the patient when you do awake prone position of those patients. Here's the kind of protocol that was recently published. So the take-home message are the following. Simple tricks allow oxygenation improvement. The Tusk mask or the double trunk mask that are described in the literature, but you can do it even simpler with a surgical mask placed on the face of a patient who is undergoing high flow nasal cannula system. You have to take the patient out of bed, make them sitting in a chair, and make them exercise out of bed. It improves oxygenation, and of course prone position is feasible in awake patient, whatever the way oxygen is provided, including with non-invasive ventilation. I thank you very much for your attention.